Thank you for inviting me. It's very humbling to hear the family journey and the story, and it really does drive us to do what we do and do it better and continue to, work hard to make sure that we're providing the best care, not for the care that we believe that you need, the care that you believe that you all need. So it's ironic because I didn't know that you were speaking first. I didn't know what you were talking about, but a lot of your talk focused on that first year. And this is what my talk is a lot about. So I think it's a common story to many people that first year of that journey, the diagnosis of epilepsy, and the journey from whether your child will continue the normal growth and the development that other children experience, or whether that pathway is going to be different. And it's sort of obviously in a room, there's a large group of people here with different experiences and different journeys, all bound by the diagnosis of tuberous sclerosis, but their journeys can be different, and parents travel that journey a lot for their children, and then the children take over that journey, and for many that are able, they also need to learn what tuberous sclerosis is and take on that understanding. So I think a lot of today is sort of talking about the wide breadth of different conditions that are associated with tuberous sclerosis within the one umbrella diagnosis, but also, as you highlighted, that transition. And that transition of knowledge is not only from the paediatric service through to the adult service, it's from parents to their children as well, where possible. And so, sorry, I'm just trying to coordinate my slides and it wants to keep connecting to the internet. So today I wanted to talk about just a little bit of overview, recognising that many people here are very knowledgeable and probably more knowledgeable than me. They've spent their life learning and understanding and trying to improve the care that they can achieve for themselves and their children. And so I want to look a little bit about what's established treatment and focus particularly on the neurological system as a neurologist, and particularly on epilepsy. I want to look at what we've been doing for years, and more importantly, the impact of emerging practice of very early treatment. The importance of early identification of the diagnosis of tuberous sclerosis and the impact that can have once you know what the diagnosis is and are able to monitor early and can potentially commence treatment early. And most importantly, this multidisciplinary approach, which we all mention, and it's hard to achieve, but we all aspire to it. So for many people, sort of diagrams like this will be fairly familiar, and highlighting that tuberous sclerosis is this very complicated multi-system disorder for which some people may only have one or two conditions, and some people will have many or all of the associated features known. For me, the neurological impact is very important and obviously a significant part of tuberous sclerosis, with up to 90% of individuals suffering from epilepsy, 80 to 90% having the subependymal nodules that line the inside lining of the brain. 10 to 15% will have the growths within the ventricles that can grow and cause problems with blocking the circulation of the spinal fluid. A large number of people will have STS-associated neurological and psychiatric difficulties with autism and behavioural challenges, and a large proportion will have learning difficulties from mild to severe. So obviously the impact of the tuberous sclerosis on the brain has a significant risk of impact on your neurodevelopmental outcome. It is also important, and sort of as a bit of a segue from neurology, but it will become relevant when I sort of talk about aspects later in early surveillance, is that in infants there is also a very, very high rate of cardiac abnormality, and that is often a first sign of tuberous sclerosis for many. And the other conditions, the skin conditions, lung, are often much later sort of components of the tuberous sclerosis complex and not something that we see in early infancy. Many may be familiar with this sort of schematic of the pathway of epilepsy, and this is genetics, and I'm sure Julie might speak to this a little later. And so our knowledge over the years has sort of expanded on the understanding of the pathway and the process of tuberous sclerosis, and it is sort of hoping to guide our treatment options and mechanisms for improving care. the pathway ultimately, and this doesn't have a pointer, does it, is really all about the cell growth, and this molecule here, mTOR, which promotes cell growth. And the genes tuberous sclerosis 1 and tuberous sclerosis 2 act negatively on the mTOR to slow growth down. And when there is an error in those genes, the cell growth continues unabated and unchecked and promotes this abnormal differentiation of growth in cells. So whilst we know this pathway, we would be hopeful that it would lead to greater translation to improvements in disease process. And I guess, this diagram, 2008, and it was not the first time this was, picture was published, yet now we are 2023, and how has it changed care? And sometimes not that much. And so, how can we make more from this? And this is the bulk of my work, and as a neurologist, I see a wide range of conditions in neurology. The largest proportion of care that I do is for individuals with epilepsy, and particularly individuals with very difficult epilepsy. And this is a common theme to many, many people with tuberous sclerosis. These MRI brain scans are two different children. They both presented with seizures in infancy. This child presented at 4 months. The child on the right presented at 6 months. They both presented with the same seizure type. This child did not respond to seizure medication, and the child on the right did. This child grew up to have very difficult ongoing refractory epilepsy, severe developmental delays. The child on the right is cognitively normal and has no disability at all. So here we have the same condition, completely different journeys, despite their first symptom being identical. So I want to introduce this concept of what we talk about in the epilepsy world, is this concept which we abbreviate to DEE because it's too hard to say these big long words. And it's the concept, and tuberous sclerosis is almost the prototype of this concept of what we call a DEE, which is a developmental and epileptic encephalopathy. And it's where cognitive function and neurodevelopment is influenced by both the seizure and the epileptiform and electrical activity that is occurring even when people aren't having seizures, but also the neurobiological process underlying the epilepsy. So for tuberous sclerosis, it's the structural abnormality and the genetic abnormality that leads to the tubers and other abnormalities that we know in the brain. That on its own can cause difficulties with development and function. But then the epilepsy on top of that can cause additional burden. And this gives rise to the spectrum that we saw earlier in terms of two individuals, the same condition, both having epilepsy, yet having very, very vastly different outcomes. So you can have an individual with tuberous sclerosis with no disability. Yes, they have the diagnosis, but perhaps they didn't even know they had it until their child was diagnosed. And so they have no disability and they've never had epilepsy, compared to a child that perhaps has some mild learning difficulties associated with their epilepsy. Maybe they're just a little bit quirky, but never really fulfilling a need for treatment or a need for additional care. They might have epilepsy. It might be just an occasional seizure, but as you highlight, many individuals with epilepsy lead a very fulfilled and normal life and can do whatever they like. And so what is it that makes this difference between somebody with isolated epilepsy and a very refractory epilepsy and very impaired outcomes? And it is those children where the epilepsy creates a significant and additional burden and what we call the epileptic encephalopathy. The underlying tuberous sclerosis at this point in time is not something that we can change once it has occurred and the baby has developed. But what we can change, hopefully, and what we strive to change is the additional burden from the epilepsy. And our treatments have been established and have really changed very little over the years. And our mainstay of treatment is anti-seizure medication. And I sort of say anti-seizure because it does affect the epilepsy in terms of reducing the likelihood of having seizures, but it doesn't do anything to the underlying process. So our medication is really just a dampener of the ability to seize. And our number of anti-seizure medications has sort of increased exponentially over the years. they're not that much better at achieving seizure control. So despite, sort of back in the 70s, we had about 3 anti-seizure medications. Now we have 20 or 30. And they're really, unfortunately, really not that much better at getting seizures under control, but the side effect profile is vastly better. And so that is certainly a benefit. And really our seizure medications, we talk about them, they're not really specific to conditions. So no matter what underlying process you have, I have my same kitty of anti-seizure medications, whether you have tuberous sclerosis or a brain tumour or you had an injury at birth. I have my same little bag of medications, and I choose the medication that is best suited to the seizure type, generally not the underlying cause of the epilepsy. And this is where neurology is sort of starting to change. Our treatments, we're hoping, are to become more precision. And so we hope that our treatments are more specific for the underlying condition, and we believe that will, provide better outcomes if we can actually be specific to individuals' underlying cause. And so we'll talk a little bit about that. Over and above our seizure medications, we have treatments such as epilepsy surgery, and we have treatments as you've experienced with the ketogenic diet, and a device called the vagal nerve stimulator, which is like a pacemaker. It sits under the skin and sends impulses up to the brain to reduce the frequency of seizures. So sort of up until sort of the last few years, our precision medicine, and so translating from that generalised any medication for any condition, there are some treatments that have developed or been used that are shown to be more precise for individuals with tuberous sclerosis. And the first medication off the rank was vigabatrin. And so vigabatrin has definitely a unique affinity for individuals with tuberous sclerosis. It is the first-line treatment for individuals with infantile spasms and seizure onset in early infancy. The mechanism of action is to increase your GABA. The GABA is the main chemical which dampens down and inhibits the excitation of brain cells, and it acts on this mTOR pathway that we saw earlier. So there is some precision to the vigabatrin as opposed to just a good anti-seizure medicine. It really does work within the model of tuberous sclerosis. And so there's good evidence of disease-specific activity for individuals with tuberous sclerosis. There's been clear evidence for over a decade now. John Osborne up in Bath in England, he reviewed all the studies published in the English literature, and this is a good decade ago now, and showed that in patients with tuberous sclerosis, patients without tuberous sclerosis, when they present with infantile spasms, only 50% achieve seizure control. So infantile spasms is a very classic seizure type, which is often the most likely presenting seizure for infants with tuberous sclerosis, and it's a sort of episode where infants will have a sort of a starfish-like seizure, and no one would think this was a seizure, and it often gets misdiagnosed as constipation or just being a little bit hyper alert, and so the infants will have these little clusters where they sort of starfish out like this, and it can often go undiagnosed for many months before people realise it's a seizure. And it is very difficult to treat, and it is highly associated with difficult and development ongoing. So in all individuals with the spasms, if you don't have tuberous sclerosis, only 50% will achieve seizure control with vigabatrin, as opposed to 95% if you have tuberous sclerosis. So it just shows you that affinity of vigabatrin for in individuals with tuberous sclerosis. So moving on from our sort of bag of anti-seizure medications, which we use for all sorts of conditions, we were very excited as we started to understand this pathway more and clever people in laboratories that you don't have contact with who while away and develop and do research and development, started to think, well, if this pathway all works through here and tuberous sclerosis is meant to actually be inhibitory on this molecule down here to limit growth, well, then can't we just come in sideways and provide something else that will dampen down this overactive pathway? And so we repurposed these medications called mTOR inhibitors. So they weren't developed for TS, they existed for other conditions. And we said, well, we'll have those, thank you. We think they'll work quite nicely for our patients. And so lots of work was done on trialling mTOR inhibitors, and most of the evidence comes from using these conditions in giant cell astrocytomas and in kidney lesions. But in treating those larger growths, which are still growing, was recognised that some of those individuals also with epilepsy were getting benefits. And so looking at these mTOR inhibitors in individuals with epilepsy was undertaken. And following on, the exist 3 trials are really the trials that we're looking at, largely around SIGAs and the giant cell astrocytomas. But through 2013 to 2015, they looked primarily at the benefit and safety of mTOR medication, everolimus, and compared to how many people were getting improvement in their seizure control. And the response rates were quite good compared to no treatment. 15% showed a degree of improvement over time. So epilepsy is this thing that goes up and down. And so when you monitor somebody, even if you don't change their treatment, you can see improvements. So you really do have to look, when you're studying a drug, to a group that aren't on the drug and a group that are, to really be able to compare and know whether it's being effective. So 15% with placebo showed a benefit, but 28% on low dose everolimus got improvement, which is good. But actually most of our drugs, when we start them, about 25% will show some improvement, so it's okay. And it's very exciting because it's sort of working on the disease pathway. But on high dose everolimus, 40%. So that's a significant improvement and certainly better than what we can achieve with many of our other medications. The difficulty is, despite this, in the advances in knowledge and knowing that pathway and really aggressive medication and using our strongest drugs and new drugs, many people, despite this, continue to have a difficult epilepsy and continue to have challenges with their neurodevelopment. The majority of infants with tuberous sclerosis experience that first seizure before a year of age, and we know that they're associated with poor cognitive outcomes. And so it became increasingly aware that we needed to get early treatment and that we needed to start something before this process was happening, because once the process is in play, it's very hard to reverse the difficulties and the cognitive impairments that have already happened. Which brings us to what's new. And this is where we really hope for many people with tuberous sclerosis that we will be able to add some real value. And this is the prevention of this DEE, the prevention of the developmental encephalopathy on top of the biological abnormalities of tuberous sclerosis. And this is what's new. Well, some people were pretty clever. In 2011, a group were wanting to talk about this, and it just really didn't get groundswell, and it was sort of, people didn't believe the results. It was a little Polish study. There were only 14 individuals talked about, and they were comparing a group of 14 people where they treated early with vigabatrin, but they were comparing them to historical controls. And so the outcomes that they were achieving, they compared to people in the past. And so a lot of people in the medical literature said, well, there's been a lot of advancements and there's better care and there's MRI scans, and there's a whole lot of other things that are happening that are good, and we don't believe that it's this early treatment that is resulting in these benefits. And so it really didn't get traction globally until a decade later, in 2021, a large group sort of watched what would happen if they gave vigabatrin early. So they wanted to diagnose, and the key was, so we needed a lot of centres to do this, to get the numbers up. Infants had to be younger than 4 months at diagnosis, and many young people with tuberous sclerosis are not diagnosed until after 4 months because they don't have their first seizure until 6 months of age, and they're not seen in the paediatric world until after this. So the difficulty is finding infants that have tuberous sclerosis under 4 months of age, and then we monitored them. They had to have had no seizures prior to this, and they had to have no anti-seizure medication. And then we looked at what the benefit was of giving vigabatrin as a preventative medication. So we surveilled these infants with a routine EEG from 4 months of age, and up until 6 months of age, this was done 4 weekly, and then 6 weekly, and then 8 weekly as they aged. And if their EEG deteriorated and showed abnormalities of increasing epileptiform activity or silent seizures, they were commenced on vigabatrin. And I'll just whiz through this, the process of time. And what we were looking for was the time from birth to the first clinical seizure. And so what we were hoping to see is that it pushed out that time till someone was having a seizure out past those critical years of development. So those first couple of years are really, really important in development. The brain is growing and brain cells are pruning and developing and pathways are being set up. And if you've got a lot of epileptiform activity, it just disrupts that normal process of neurodevelopment. And so we were looking at the time to the first seizure, and then secondary outcomes is at 2 years, what was happening for those children. Were they having seizures? Was their epilepsy controlled or was it refractory? And most importantly, how were they functioning? What was their neurodevelopmental outcome? And so vigabatrin chosen for the reasons we've talked about before. And these are the results. And so this is the group of children. So obviously when you enter the study, 100% of people are seizure-free. And as time goes on, the children not on preventative treatment, that they rapidly became not seizure-free. So within 180 days, 50% of people had started having seizures. Compared to those children on preventative treatment, it really pushed the onset of their epilepsy out. There were two arms. Some people didn't want to randomise and just wanted to treat based on parents' wishes. And so there were two groups, a randomised group that were blinded to what treatment they were getting, and an observational group where they knew, but they were still either treating when seizures arose or on the preventative treatment, and irrespective, there's a significant benefit in early treatment. And so the outcomes, it was 4 times longer to the first clinical seizure in the preventative group, 3 times more likely to be seizure-free at the age of 2, which is just amazing. Reduced frequency of infantile spasms, which is our prototype of the infantile spasms, is just a marker of the whole brain. Even if you've got a seizure coming from one area, the whole brain's getting involved and causing difficulties. No children on the preventative treatment developed infantile spasms. So 2 times the reduced frequency of drug refractory epilepsy at 2 years, 28% versus 64%. No adverse events related to the preventative vigabatrin treatment. So preventative treatment with vigabatrin at onset of abnormal epileptic activity showed a significant improvement in clinical outcomes, and this is really largely with respect to seizures. But what about the development? So of the 80 children enrolled in the study, at 2 years, there were 33% of children were diagnosed with a degree of developmental delay versus 50% with the conventional treatment of waiting and no prevention. So I'll just sort of saying the same. So 4 to 6 times more likely to have developmental delay if you do not get preventative treatment. So all without epilepsy or abnormal EEGs had normal intellectual function. So this is the most exciting data that we've been able to, show for a long time. So certainly, even in the absence, because we're sort of collecting a whole lot of, I say we, it's not me, me as my global international community, irrespective of the epilepsy, a lot of data was collected and some more information came out over in terms of predicting outcome at 2 years of age, and some just reinforcing what we already know in terms of individuals with tuberous sclerosis with a mutation on TSC2 versus TSC1 having poorer outcomes, and milder presentations. And there was a little bit of work on looking at fetal MRIs and trying to determine whether you could predict by their abnormalities even seen before birth their likelihood of developing developmental difficulties. And so there were some scores, but I think we'll skip over that a little bit. So prevention requires this early detection. And so it's all very nice in the study and very controlled environment, but how do we do this when individuals are only presenting when they have their seizures and it's too late then? So prevention requires early detection, and for individuals that know that they have a family trait of tuberous sclerosis, that is imminently possible, because at birth you can say, well, I have this genetic condition in my family, I would like my children tested, and therefore, if you are positive, we can potentially treat. And there are some other features that perhaps lead you to wonder about the tuberous sclerosis. Somebody has to pick up on these. So these skin lesions of hyperpigmented lesions or hair patch, But most importantly is these cardiac rhabdomyomas, and this is why I mentioned them very early, because increasingly with advances in pregnancy care, we get very detailed antenatal ultrasounds, and these cardiac rhabdomyomas are picked up on late antenatal scans. And so if the cardiologists know about them and the fetal medicine panel know about them, they can talk to us, and then we can come and meet families in the newborn period and say, well, look, these cardiac rhabdomyomas are highly associated with this wider condition of tuberous sclerosis. We need to look into this for you because there are some definite advantages of knowing and managing early. So just highlighting the features that are seen at birth or potentially can be seen at birth that could lead us to a very early diagnosis. Obviously, some of these features you're not going to look for, all newborn babies are not going to go to the eye and can you have a look in the back of my child's eye to see if I have a feature of tuberous sclerosis? That's unlikely to happen. But skin lesions and cardiac lesions and family history are all pieces of information. It's not going to capture everybody, but it will capture many. So cardiac rhabdomyomas are these rare tumours in the heart. They're often asymptomatic, but they are noticeable on these antenatal scans. Sometimes they do lead to abnormalities of heart rhythm, and babies present with a very fast heart rate in infancy that needs to be managed. And certainly the cardiac rhabdomyomas, it would be difficult to sort of use this as a marker to then diagnose tuberous sclerosis if there was not a high correlation with tuberous sclerosis. But in people with rhabdomyomas, 60 to 70% of individuals will have tuberous sclerosis. So the vast majority of people with rhabdomyomas and of cardiac origin have tuberous sclerosis. A very small proportion have it in isolation, but it is a really good marker, and certainly we're not going to be going and having a lot of talks with a whole host of people and worrying them about a condition that they don't have. It's a very small minority that will not have tuberous sclerosis. But it does, highlight this importance of this multidisciplinary care of teams needing to talk to each other and involve other people. And so we need information from maternal fetal medicine, cardiology, genetics, and all work together to improve outcomes for children. And so just briefly, sort of the elephant in the room is this vigabatrin, isn't it? Because I'm sure that if you yourself were ever told that your neurologist wanted to start vigabatrin or talk to you about starting it in your children, they did sit you down and say, look, we'd like to start this. It's a really good drug. You do need to know, though, that it has these really bad side effects on the eyes. But we think it's a really good thing to do because, on balance, a little bit of visual loss versus improving neurodevelopmental outcome, on balance, you choose the neurological benefit. And so, but of course, that worries people. We don't want to cause harm. We don't want to cause complications and visual difficulties. But the good news is we got it wrong. Vigabatrin does not really cause visual problems. This is huge. So what happens is that there was a possibility of vigabatrin causing visual problems, and people went looking for it. And so people went to eye doctors and noticed abnormalities in vision. But it was all based on retrospective data. They were already on the vigabatrin. And when we looked at it, long-term use, which we thought to be up to 40%, one, it wasn't particularly severe and it didn't usually cause functional problems anyway. So most people, even if they did have what was thought to be vigabatrin-associated toxicity, did not want anyone to take their vigabatrin away from them. It wasn't a worry to them. But because the Americans are so fussy and they get sued if they cause problems, they had to monitor this prospectively. And what they did is once they started treating people with vigabatrin and monitoring them, they got baseline assessments. And actually all these visual problems were present at baseline, bar a very, very small minority. And so when they looked at it, they had pre-existing visual pathway difficulties. And so data reviewed only about 2% from this, we would quote 30 to 50% would have difficulties with vigabatrin. Actually, the reality number is probably around 2%. And so 98% of people can use vigabatrin without causing problems to their eyes. And this has been sort of shown in a number of studies. In Boston, they looked at ERG patterns, which is sort of a very difficult test that you need to do to monitor the toxicity, which in children is impossible. So we always had to compromise and use vigabatrin and say we weren't going to monitor it because it was, impossible to do. Actually, you don't see changes anyway. So it's great news. So the evidence of vigabatrin-related ocular toxicity in children is incredibly low. Obviously, this, we need to keep monitoring this and keep an eye on it. But the likelihood, 0.7% of definite toxicity and maybe 1.4% of possible toxicity when it's been looked prospectively, which means, going forward rather than assuming. So our recommendation currently for surveillance of infants with confirmed or probable tuberous sclerosis is to obtain these EEGs in the pre-symptomatic period in infants with tuberous sclerosis, at diagnosis in the neonatal period if we can, and then every 4 to 6 weeks up until the age of 12 months until we begin to treat. And obviously this is, in an ideal world, and not everyone lives close to an EEG machine, and there are resource implications. So we have a golden vision, and then somewhere in terms of in practice, it's probably somewhere in between what we were doing and this, but it's a start, and it's certainly, a good thing to be able to offer. So the key is for everyone to talk to each other and consider the value of EEG and early monitoring. So take-home messages are that early diagnosis of TSC should lead to the frequent surveillance of EEG, identified by cardiac rhabdomyomas and family history, and that early treatment improves outcome. And vigabatrin's not that bad. So, questions?
Haven't forgotten. Thank you. I don't think it needed a mic, but anyway. So in our case, Dr. Claire, and we met you at Starship, and you were amazing. So thank you for what you've done for families and people, babies. Marin was initially put on vigabatrin, and we had a fantastic response, but it was all around the time, so this is 1998, where they had discovered there might be this visual field implication. So they took her off it, and we had to go then onto quite a cocktail of meds which caused some issues, some liver problems and bits and pieces. But so what you're saying now is vigabatrin is, you wouldn't have to give families the same sort of...
No, we don't screen at all now. It's a little bit, it sort of takes a while to, even for us, to say, well, we're not going to send you to the eye doctors to monitor. So eye doctors aren't particularly keen for our referrals anymore.
That's fantastic. Woohoo.
A couple of other questions?
Hi, I just wondered, how do you do a neonatal EEG?
So it's just the same as an EEG on anyone. It's just, smaller spaces between the smaller surface of the brain. So neonatal as in once they're born.
Right.
Yeah.
Okay.
Not before they're born.
And they're quite sleepy, aren't they? So they kind of...
They don't fight quite so much.
sometimes go to sleep quite easy. Any other questions all clear? You're going to stay around for a little bit too, Claire? Yeah, so you can ask a private question too a little later if you'd like.
Claire, I'm Jackie from TS Australia. So I just wanted, I'm assuming you're aware of the TSC STEPS research trial taking place in Sydney?
Ooh, fill us all in.
Okay, I just wanted to mention it. I'm probably speaking a little out of turn because I'm not sure that people from New Zealand are eligible, but I suspect they are. And it's at the moment it's basically looking at the or its potential looking at the impact of mTOR inhibitors in those children at a very, very early stage. So it's for babies who are 0 to 6 months old with a diagnosis of TSC, which, as you say, is not always the easiest to actually have. But that trial has recently started up. It's in conjunction with a number of research centres in the US as well, and being led out of by Dr. Darcy Kruger, who is a very well-known neurologist. And I know that certainly it's although it's all being administered out of Sydney Children's Hospital, I know that everyone around Australia is invited to participate if they, have an eligible child. And if anyone from New Zealand who had a baby of that age,
I think it's the
was
difficulty
eligible.
in the surveillance of needing to attend for the routine EEGs and and the multiple trips.
Absolutely, and I'm not entirely sure how many trips are involved, but it could just be worth mentioning as one of those that is on the horizon, is taking place, and hopefully could have a big impact.
And I
going forward
guess
as well.
the difference between the mTORs is very much on inhibiting cell growth, and for a lot of tests in the epileptogenicity of the lesions, those lesions have already occurred, and yes, there is some additional process that happens because we do know that mTORs are effective. It cannot remove the structure and the lesions that are already present, but absolutely another tool in the kitty, as we say.
I get to say the thank yous to you. I'll hold on to this. So thank you so much, Claire. Really wonderful to hear about the new research and the things that are improving for our babies and maybe our next generations. Thank you for your work.
And whilst I've been here, obviously I have a connection with Helen, all our neurologists have a huge passion for managing epilepsy in children with epilepsy, and Melinda Nolan has done a lot of work, so I should give her credit. She actually prepared most of these slides because she gave a talk to another group recently, and has done a lot of work in trying to get funding for medications like mTOR inhibitors more readily available. So big thanks to her as well.
Yeah, thank you.